let you take it away.
Okay. Well, trainees, are excited to be here to come back and talk with you on this case discussion presentation on childhood apraxia speech, which is something that I have population that I've worked with for a long time for both diagnostics as well as providing them with appropriate AAC interventions. As you see, I'm retired now from DDBP, but for 20 years, I was your speech pathology LEND faculty person. This past semester, I finally retired from UC, and there I had been teaching and research in AAC. However, I found a new passion, and I was invited to become a faculty member of the Rocky Mountain University of Health Professions, where I'm going to be a capstone content expert in AAC for their Doctor of Speech Pathology program. So it's going to be a wonderful way to allow me to continue to mentor students in my area of passion and research. So it's going to be an exciting transition. So far, the students that I've been working with are phenomenal. It's all Zoom oriented, so it's easy to be able to do. The students are from all over the country, from all different backgrounds, and so it's been fun to do as well. So, Karen.
Thank you. I had a chance to monitor the chat a little bit, and someone wrote, Sandy Grether is a legend. It's so true. She's so modest, but we are so lucky. I feel very lucky to be partnered with her to do this. And so people might ask, so why am I talking about childhood apraxia of speech when it's really a speech diagnosis? But childhood apraxia of speech is a neurodevelopmental disorder, and it has so many comorbidities with it and can affect so many neurological systems that's why it's a really crucial diagnosis to discuss from the perspective of the whole child and the neurologic impact. So I'm Karen Burkett. Many of you know me, I think, and developmental nurse practitioner and a nurse scientist with developmental behavioral pediatrics and graduate nursing faculty. So for LEND. All right, so let's see what advances things. That wasn't it. That wasn't it. Okay. Nope, that didn't do it. Sorry. Okay. There we go. Sorry. All right, finally found it. So we're going to start first with.
Except we lost it, Karen.
Oh, you lost the picture?
Yes.
Oh, okay. All right. Wouldn't you figure? I always mess something up. All right, let's get you back. There we go. Okay.
Now we're good.
Now you're good. All right, here you have a lovely picture of the brain. And so each part of the brain, of course, has their own function. And the temporal cortex is the area that is involved in awareness of how you use language and also has a role in memory, which is here. This is the temporal lobe. Can you see my cursor?
Yes.
Okay, good. All right. And so then we have the frontal cortex, or the frontal lobe, which also involves the motor strip. And this is the motor strip right here in the front. The frontal lobe looks at, it's like the mother of your brain. It is the way you function, your executive function, you're initiating, you're prioritizing, you're recognizing what's important, you're completing tasks. And look how close this is to the motor strip, which is called the prefrontal motor cortex. And this is involved with not only motor movement, but also attention and movement, attention and memory related to movement. So this is the homunculus man, which gives you an idea of what part of the body is innervated. And right here is the movement for the lips, the jaw, the tongue, and the throat, right next here to the motor strip. So you see how close this area, which of course is related to speech, and this area of the temporal lobe, which is involved in memory and language, and this area of the brain of the parietal cortex, which is important to spatial orientation, touch, pain, and also linked to memory. All of these pieces must interconnect in order to understand speech and to express it, and to put language together to do that. Some of the specific speech areas are Broca's, which is where you have the reception of speech, and Wernicke's area, which is where you have the understanding of speech. And so what's important to understand also about this neurologic disorder is that, so if you're right-brained, that means your dominant side is your left side. So let's say you're left-handed, then typically your right brain is considered your dominant side. And so that reverses. If you're right-handed, you're more dominant on the left side. So when it comes to language, that dominance is established by whether you're a right-handed or a left-handed. Some people are more ambidextrous, but that can affect your where the language stems from, or where it's grounded in the dominant lobe. Whether it's right or left doesn't matter. It's the dominant lobe that's important to know, particularly when you're doing things like brain surgery, right? And I used to work with brain surgeon. I used to work in neurosurgery, so that becomes very important. So, so Broca's area, this part here is about producing the speech, and Wernicke's area is the part where you understand and comprehend speech. So Sandy is also part of the team with, I think it's Erin Riedel. Is that how you say her name, Sandy?
Yes.
Okay. And in 2014, Sandy and her team, they worked on a study looking at functional MRI of children with speech sound disorders like child apraxia of speech. And functional MRI is where they have you do a movement or maybe read something while they're doing the imaging using the magnetic resonance imaging scan. And so they examined children's speech as well as non-speech activity. So they asked them to touch their finger to their nose, that sort of, coordination activity. And what it showed was that multiple areas of the brain would light up when the children were speaking. So it's not a singular feature like Broca's areas and Wernicke's area, but it's the circuitry that's involved in all of these connections that make the difference in producing and understanding speech. And that was a huge finding. In fact, we used to do MRIs of children with childhood apraxia of speech, and I'm talking, that was like 15 years ago when I first started in this division, and found that showed us nothing, because all the connections are within the circuitry of the brain at the molecular level that you cannot see on MRI. Now, the functional MRI is different and was able to show us areas that light up with movement or with speech. So there are other studies, other neuroimaging studies that have been done looking at, I think you've all had some exposure to developmental coordination or coordination disorders, and how that is more like a motor dyspraxia or a motor planning, initiation, coordination issue. So neuroimaging studies looking at children with motor coordination disorder, like childhood apraxia of speech is a speech coordination disorder. That's a motor coordination disorder. And Zwicker in 2011 found that on neuroimaging, children with motor coordination disorders had underactivation in brain regions that were associated with motor learning. And so finding this was really key to understanding why children with coordination disorders like a motor coordination disorder, have difficulties with memory of that experience, like learning to tie your shoe, for example. You have to have that memory of doing that again and again in order to make it part of your coordinated movement. Your ability to plan was underactivated in children with these neuroimaging studies. Okay, before we look at this video, I'd like to tell you about our case presentation today. So this is Oscar. He's 4.5 years old. I want you to notice some things. He is a child with coordination disorder of speech, so childhood apraxia of speech, and he has a motor coordination disorder. I want you to look at his personality, what kind of temperament he has, what bothers him, what doesn't bother him. I'd like you to pay attention to how much he works or doesn't work to try and communicate. So see if you can give an opinion on that. I want you to notice his difficulties with his speech, his expressive speech, or things that he is able to speak well, areas that he doesn't have difficulty in. And then I'd like you to take a look at his movement, when he's sitting still, when he's not sitting still. I'd also like you to look at his face and see if you can notice anything about his face or even his shoulders that might be a little bit more, little bit less typical than what you might expect for a child at 4.5. And I want you to look at coordination. Some of those things might be, as he leaves, he opens the door. As he leaves, he blows a kiss. So look at some of those things. So at this age, he's got a mild developmental delay. He's got coordination disorder. He's got sensory integration disorder. He has childhood apraxia of speech. And he's got some attention and focus difficulties. So without further ado, I'm going to see if I can make this work. I think if I just go here, it will. Okay, nothing is happening for you, right? Okay, click on it here.
Yes.
Okay, I think I have to make my screen small. I'm going to share a different screen here. I'm going to share the one that I've pulled up. I know people do this so smoothly. I am not one of those people. Okay, can everyone see that?
Yes and no.
Okay, I'm going to move it back to the beginning.
There.
Got him?
Yes.
Okay, I'm going to make sure you let me know that you hear it.
Hey, hi. What's your name? Jackson. Oscar?
We can hear it.
Do you go to school? Hey, sit back, please, honey, okay? What are your friends' names? What are your friends' names? Sammy and who else? Rachel, who else? Zachary. Do you remember your teachers' names? No, that's your friend's name. Is one of your teachers Miss Joe? Marlene. Miss Marlene, and who else? Teacher? Teresa. Miss Teresa? Yes. Oh. Sit up like a big boy. Who do you think? Miss Janelle? Yeah. You like Miss Janelle? Yeah. He's starving. Come on, he's starving. Okay.
Karen, I think multiple people might be having it, but it's really choppy. I'm not able to hear much of any of the conversation. It's just kind of chopping. I don't know if most people are having that or not.
Oh,
I just wanted to make you aware.
okay.
6.
Is there a way to put closed captioning on the video maybe so that we could at least like watch what they're saying?
Where does the word on the bus go? What about fuck? He says move on. Happy or sad? You're happy. Why don't you smile? Are you tired? Yeah, Mom. Let me kisses. Let me kisses. Hold on. Thank you. Ready? Hi, Mommy.
Okay. So that was a fail, I understand. You could see it, but you couldn't hear it.
It was just very, very broken up. So it almost was like it was buffering kind of off and on the whole time is how it presented to me.
Okay. Oh, this is so much better in person. I'm so sorry. It must be going through multiple internets. And I heard someone ask for closed captioning, and that would be perfect. I know we have it for this session, but not for the video. So the other videos are different. They're embedded. And I think when we've done them before, they've worked. So we'll continue.
And you do have this link on the presentation. So outside of this presentation, if you have a few minutes, you might want to go and pull it up yourself and listen to it. But I think you saw a lot of his motor movements. Initially, it wasn't doing too bad. We could really kind of hear more of his speech patterns.
Yeah, so with that in mind, Sandy, if you would mind talking about his intent to communicate and kind of what you heard in terms of how he was saying things that might make him a candidate for childhood apraxia of speech.
Well, some of the things that we saw with Oscar was that he does not know that he is not producing or reproducing what he's being asked to do. The therapist or the researcher that's doing this, she's saying it and he's like, but I said that. And so in his brain, he really thinks that he is producing it even as exactly as she had. Even with the simpler words that we were taught or that he was asked to produce, he was still having significant difficulty with those as well. You will see with his facial expressions, he tries to do what we call groping, where he thinks if he moves his mouth all the way around and doing these things, that helps him speak better. But it really doesn't make any change in the actual production. Let's see.
That's great. That's what I was hoping for. So you could see that he wants to communicate, even though he doesn't have the insight to know that he sounds not like they are working to get him to sound like. Did you note, what did you all notice about his face? About his motor movements? And for those of you that couldn't see it that well, maybe I'll just describe it. So if you kind of look at his face, he's kind of got that open mouth posture. Did you see that? When you could see it, he was using more an open mouth, kind of a lower tone in his face. Even when he smiled, you know, he smiled, but he had a great smile, but you could see that just the face, he had lower tone, his shoulders were kind of slumped, and his coordination as he was looking out the door to leave, his blowing a kiss at 4.5 was not exactly the kind of smooth coordinated movement that you might see from a 4.5-year-old. His personality was just delightful, right? I think everybody saw that in terms of his temperament, and he didn't quit. You know, even when he was corrected, he didn't give up. And the fact that he had some trouble sitting still, and so focus was an issue too. Is there
Jim was
anything else?
asking, are there higher incidences of, went off my screen, of anxiety and depression in this population since they're unable to communicate what they want?
Oh, absolutely. What we do see, it's not so much, anxiety is more something that is innate with you, but we have many, that is one of the comorbidities, but what we see is more adjustment disorders. Will children manifest with anxious-like behaviors or emotional struggles because they have to adjust to difficulty like childhood apraxia of speech that is different than other children their age. So it's a big adjustment. Okay.
I would imagine too that, because I know that this is something that goes in that we see a lot of times cross disability, a lot of sometimes things, and a lot of things that can go into depression or anxiety or some other sort of things. And some of that also too comes from the fact that when you're told you're bad or wrong, or that you don't do things right or stuff, or that you need to be different than who you are in some ways rather than sort of an accepting sort of way, that can create turmoil within some of that. And so, I mean, I think that's always one of the things that is we're looking across disability, and we know that there's also some of those things that we have to be mindful of.
Excellent point. Thank you, Jason. Okay, so the next piece is we want to talk about what is part of the neurodevelopmental evaluation that is done. And so that would include your health history, that includes communication history, your birth history, pregnancy history for the mom. What are the developmental milestones? At what age did the child obtain toilet training? At what age did the child walk and talk and sit? What kind of services has the child had in communication or not? What kinds of evaluation? What's the oral motor? So you can do things like ask the child to blow a kiss and see how coordinated that is, because that's a very complex movement. You can ask the child to reproduce simple syllables. Pa, ta, ka is one of the 3 syllables that are difficult if you have childhood apraxia of speech to reproduce. You want to know about the child's motor skills. And that includes your fine movements, your upper body movements, any sensory struggles, your running, walking, and then behavior. What is going on in terms of behavior? Is this the child who hides when they're in school or hides at home, or is extremely shy? Or is this the child who is, right in your face and who has some trouble with personal boundaries, or none of those issues? What's the sleep and diet like? What's the previous educational interventions? And in the physical exam, that's where you would look to see what their coordination is like. You would ask them to stand on one leg. You would ask them, you would check their reflexes, check their cranial nerves. And that's where some of those tone pieces would be apparent that you might have seen with Oscar in the facial tone. And someone was asking about comorbidities. So anxiety can be a comorbidity, but does not occur as often as these. So in children with childhood apraxia of speech, generally you can see at ADHD, attention deficit hyperactivity disorder, either the combined type of impulsive and inattentive, or just the single inattentive type. You can see that about 50% of the time. You can see a child with a coordination disorder, DCD, about 50% of the time. You can see other speech and language difficulties. So they might have a language comprehension difficulty. They might have other speech sound disorders other than childhood apraxia of speech. They might have pragmatic language difficulties, understanding how to use conversation back and forth. And there might be learning disabilities 25 to 30% of the time. So motor speech disorders can be,
That's my part.
there you go. Thank you. No wonder I'm stumbling. Thanks, Andy.
Yeah. So what we see when we look at the overall group of individuals who have motor speech disorders, by using a speech disorders classification, we were able to, in the Schreiberg study, to be able to look at all of these children. They researched children 4 to 8 years of age, and these had essentially been children who had what we call an idiopathic or just a generalized speech delay. When he looked at the research, what we found then was that out of 1,000 children, that 4 of these children continued to have a chronic speech motor delay. 1 child out of 1,000 had childhood dysarthria. Dysarthria is kind of a slurred speech pattern. We see that sometimes with children who have cerebral palsy. Only 1 child had a pure diagnosis of childhood apraxia of speech, and less than 1 had a concurrent childhood dysarthria and childhood apraxia of speech. So a very small number still actually present with both. And these are probably our most difficult children to be able to work with. Erin, go to the next slide. So this is going to be our working definition here for childhood apraxia of speech. I want you to think about, these are going to be children who are going to have difficulty, not just explicating, but actually also coordinating or sequencing any of these oral motor movements that we saw that are going to be necessary to produce and combine then consonants and vowels to form syllables, words, phrases, and sentences that are going to be under their volitional control. So we're going to go to an example to see how we're going to parse this out. So think about a word that you want to say, and I want you to think this is going to be your word, cat. Everybody have this in your head? Okay, you're now thinking cat. And now I have to think about how am I going to break that down into segments. So we need to think that cat has the k in the back of the throat. It's an unvoiced sound. Then I have a, which is a vowel. It's centrally located in my mouth and I voice it. And then t is going to be in the front of the mouth and it's going to be an unvoiced sound again. All right, now I have to plan how I'm going to put all 3 of those movements together in order to be able to sequence them to be able to speak my word. So you can see how difficult it might be even for someone with childhood apraxia of speech to do even a simple word. Now here's your next job. I'll give you a few seconds. Here's your word breakfast. That's what you're drawing from your lexicon. Break it down into segments. We have b, e, a, s, t. You're going to have to plan how you're going to put all those together, put that sequence together, and now speak your word. So you can see where a child's going to have significant difficulty with childhood apraxia of speech, even with these simple words. And we don't think about it. We think about, I'm going to say cat, it comes out of my mouth. I'm going to say breakfast. I'm hungry. It's going to stay out of my mouth. But to think about what has to really go through the brain to be able to put those together. Karen? Next slide. Okay, so we also need to have a very comprehensive speech and language evaluation when these children are referred for any speech sound disorder. So you're going to see this across the board. It needs to be comprehensive. So I'm once again going to be taking a case history. What does the family look like? What other things have been happening with this child? I also have to make sure that I have a really oral mechanism examination. So I want to see that if the child, can they move their tongue around? Can they open their mouth? What are the things that they need to do just to orally manipulate the tongue, their mouth, their lips, all of those things that are going to have to be coordinated to be able to produce that sound. We always want to do a hearing evaluation to make sure that there are any issues there that we need to be concerned with. And not there yet. And then receptive and expressive language assessment. We're talking today about more preschool children. So the preschool language scale is a good one, or the clinical evaluations of language fundamentals. So the CELF is another good one. But we want to be able to make sure we know what they're understanding as well as what they're able to express. Karen? Then continuing, I need to really make sure that I look at all the speech sounds. I want to look at those sounds in single word testing, as well as when I want them to connect it some kind of a speech sample to see, does it break apart when I ask them to do more sophisticated sentences. We have two test evaluations we can use, the Goldman-Frischshow and the Kaufman. The Kaufman is one that we'll often use if a child does not have enough words to be able to produce it. The Goldman-Frischshow requires them to have words. But the Kaufman backs up to where I, in the initial phases, just asking them to repeat back vowels. Then it builds on putting together consonants, putting consonants and vowels together, and then it proceeds through a level of complexity depending on where the child is and what we need to assess. If they're coming for a speech and language evaluation, I also want to know what their pragmatic or social language looks like. Both some formal or informal assessments can be done. Because we want to know, is this impacting their ability to communicate socially in the environments that they're in? If indicated, we want to do a literacy assessment because we want these kids to be reading. And Children's has a fantastic reading literacy discovery center that we can refer to if we think we have to have this in a more complex manner. Next, Karen. So if the child has childhood apraxia of speech, what am I expecting their speech to sound like? What I'm going to see overall is they're going to have very limited consonant and vowels in their system. And sometimes they may mostly have vowel sounds. We're going to see frequent sound distortion. So not just a sloppy speech production, but sometimes complete sound substitutions for consonants. We see that automatic speech is going to be easier for them to produce, but sometimes we'll have kids that are very good at saying, I love you to mom, but couldn't take it apart and say, I love you in any other context. So we're looking at, what do volitional utterances look like? So any novel phrases or sentences. So I might have them tell me a story or something to fill in to be able to see how that, or to repeat back something that maybe they ate for breakfast. We do see these kids also have better performance on speaking tests that require what we call single postures versus more sequences. So at the simple level, it's just being able to say the ah versus the ah and mama. Karen? In addition, we sometimes see some of these groping behaviors, and these are kind of some of their attempts to be able to bruise some of the sounds. Some of our kiddos come up with really over exaggerated movements of their mouths. They're thinking that that might be helping them to produce these sounds or to co-articulate the tongue and the mouth movements. We're going to see differences in their what we call suprasegmental characteristics. So these are going to be things like their rate, their pitch, their loudness, And then voicing errors are the difference between voiced and unvoiced sounds. So in our example, the K is an unvoiced sound, a G is a voice sound. Some of our kids have voicing errors in which they do not produce any voice sounds, or maybe all of their sounds are voiced. We're going to see these kids have difficulties with producing longer or more complex syllables or word shapes. We saw that in cat versus breakfast. Some of the times we'll see atypical, what we call levels of regression. So they might have had some words or sounds early on, and then they've lost them. And then the other characteristic that we're seeing often are a lot of these children didn't even babble as infants. So in 2007, ASHA came up with a consistent diagnosis that they wanted us to use for any childhood apraxia of speech. So the basic components are going to be these children must have inconsistency across their words and syllables. They must have difficulties and lengthen or disrupted, can't even say that, co-articulatory transitions. So that means moving from the simple sounds to the more complex sounds. And that can be within words or within sentences. They're also going to have inappropriate prosody. So that means that we talked about the prosody being like rate and pitch and loudness. Those are going to be difficult for them to be consistent. And any clear intent to communicate, though, these are kids that don't have a diagnosis where they don't want to talk. These kids all really want to talk, regardless of their age and severity. And just as you saw in our little example, he wants to talk and he's thinking he's doing a great job. So the social piece is usually not there unless they're starting to have some negative impact on having the speech that's not understood. So what happened in 2019, Overby and his colleagues started looking at, could we have a consistent study to be able to look at infants and toddlers? And what would that look like? So as he studied, and I forgot the number in that sample, but it was significant, but he was able to start for the first time to be able to put together some guidelines for what a potential diagnosis for childhood apraxia speech would look like. These are children that have already had limited vocalization in their first 2 years, especially for sounds in their native language, because this is not just a US diagnosis, this is a worldwide diagnosis. These are kiddos with lack of consonants by 12 months of age. They're using fewer than 3 consonants by 16 months of age and or fewer than 5 by 24. They have limited to no velar. We talked about the k and g. That's difficult for them to produce, but they're usually pretty good at these frontal sounds. So stops are like p, b, t, and d. And then the nasal sounds are usually easier for them to produce, m, n, and ng over other consonants. We're also seeing that productions at even 13 to 18 months for many of these kiddos are largely vowels with little use of other syllable shapes, so such as consonant, vowel consonant shapes. Why is this important for us to be able to do this? We want kids to be in treatment and effective treatment as early as possible. We don't want them to have to wait till they have a formal diagnosis, because usually we didn't have enough research to really support it until they were more in that preschool age. But we want our kiddos to have it. If it doesn't, if the treatment is not really affected towards the types of difficulties these children with childhood apraxia speech are having, it may not be effective in gaining the skills that we want them to have.
I'm going to unmute here because I realize some of my difficulty here is I'm using 2 screens and my second screen doesn't have volume on it. So I'm going to discontinue. I'm going to stop sharing and we're going to set it up for this next because this is a video and I think it'll be more effective if we do it another way.
Okay.
Give me a minute.
There was also a question in the chat. Jason had asked, I'm curious if, I think this is from your slides, Karen, if comorbidity is the best term or maybe co-occurrence, just based on the perception of what morbidity has.
Could you read the question again, Angel? Thank you. I think I understood it, but I want to be 100% because I was in part doing something technological and that challenges me. Try it again.
It says, I'm curious if comorbidity is the best term or maybe co-occurrence,
Oh.
just based on the perception of what morbidity is. Yeah.
Oh, what a great question. So no, I didn't have that question right. Yeah, comorbidity is a medical term that just talks about co-occurring diagnoses. But the term morbidity does sound just horrible. You know, you think about morbidity and mortality. Those are the rounds that typically we have when children or adults are hospitalized. And so co-occurring, it's similar. What the study did was they looked at co-occurring, I'm going to change that in the slide, you're right. It's all about wording. Those co-occurring morbidities, those co-occurring diagnoses were as the result of surveying families who had child apraxia of speech and what other conditions did their child have. So thanks for the question. Good point. We'll do it. All right. So let me get rid of my second screen here. And while we are doing this, I wanted to just point out for those of you that couldn't hear Oscar's speech, there was a point in time when his mother was asking him the wheels on the bus. You know, she was doing the preschool song, the wheels on the bus with him. And what he said was, mu ah ba. So it kind of just supports what Sandy was sharing about the kinds of vowels that he had and the common consonants, or what do you call the M's and the B's? Are those phonemes?
No, phonemes.
Phonemes, okay. So he had the mu, ah, ba. So we had the B and the M, but everything else was a vowel. And even when she said, I love you, Oscar, and he was repeating back, love you, he said, wa you. You know, so he had all of those vowels and some of those common phonemes that children with apraxia of speech, but the consonants just weren't there. So just wanted to point that out in case you couldn't hear that. Okay, so let me share my screen here. Okay. There we go. And we are on this slide here.
Yep.
Okay.
So we're going to be showing 2 videos of Aaron. And what I want you to see is he's using Touch Chat Word Power to support his verbal language output. So the speech pathologist during this video is coaching him regarding where to find new vocabulary. Then once he creates his message, he then speaks it verbally. And if he wants to speak the message using his device, then he has for an additional model, he can do that as well with the system. And Aaron is now 13 years old. So Karen reported at her last visit with him that he's no longer using a device and his speech is very intelligible. So it really points out to the effectiveness of having an AAC treatment protocol in place. So
it does.
So you need, yeah, there you go. Karen, I can't hear it. Karen, I still can't hear it.
Right.
Can you start it over?
Sure. Sure. I'm not sure why you're not hearing it. I've disabled. No, sorry. Hang on a minute.
When you shared your screen, did you share with sound? Do you know?
So let's do that again. Okay, so we'll stop sharing and I'll go back to the slide we want to do. And so when I share my screen, there is not an option that I've seen. Let me find you all again. Okay, so share screen and let's see what it says. Who can share? Okay, who can start sharing? Only host. Okay, all participants. All right, so share my screen. And share sound. Okay, I see a little box now. Oh, genius. Thank you. Okay, share sound. First screen. Let's do that. All right. Now I have to find you all again. Okay, do you see what I'm seeing where it says who can share? All right, get rid of that. There you go, from current slide. Can everyone see that? I'll try it again.
Yes, that's
Okay,
good.
and it's cranked all the way up, so we should be good.
We're going to say if it's a he or a she, right?
Yes.
I'm sorry,
So
whenever
you
I
know how to
click
do
on it.
that. You go to your people, right? Oopsies. Oops. It's okay. Good. Mm-hmm. And then we say is, right? He is. And what is he doing with the ball?
Throwing.
Very good. So he's throwing the ball. So we can go to our actions A to Z right there and find the T. Yep, because throwing starts with a T. Now let's see if the word, oh, you found it. Perfect.
Throw.
Now, do you remember how to add? You have to add something to the end of throw, right? You're close. Throwing.
Throwing.
Good. Okay, say the whole thing.
He is throwing.
He is throwing, and then you say it too.
He is throwing.
Very good.
Let's do it.
Okay. Are we ready to move on to the
Yeah.
second one?
Yes.
First,
It's just
tell me
another.
what he is doing.
And sleeping.
That's right. Okay, so now we're going to use your talker. So we need a pronoun. So we need, yep.
He
Good.
is.
Very nice. And then now let's see. If you want, you can see if it's on the next page. Do you see sleeping? Oh,
Sleep.
very good.
In. Sleeping.
Wow, nice job.
He is sleeping. He is sleeping.
Perfect. That was awesome.
Yes, when in the very beginning of the tape, if you heard him, he had barely an approximation of each of the words that he wanted to present. But by having that visual representation, coaching him through the language pieces of it, we're finding our children are much more effective in being able to know that I need to add a verb ending. They're not really producing it on their own, but when you coach it using the language system, it becomes much more powerful to these kids. And many of our kids will, in therapy, what we encourage them to do is to say the word out, but if then they need to, they can use the device to speak it as well. He initially was using the device more for his model each time, but then as he proceeded in therapy, he dropped that altogether to where he was creating it language-wise to be able to give him all the language cues he needed, but then was able to speak it without any difficulty. And as Karen said, that he's no longer using the device and his speech is very intelligible. Though sometimes what we see with these kids, they still might have difficulty with appropriate intonation, that's something that we see with some of our children, not all of them, but it's one of those more complex levels of prosody that you put onto your language that still has some difficulty for some of our kids. Okay, Karen. I'm glad those worked.
Yes.
Okay, so what does speech and language treatment look like? Because we want to be able to make sure these kids are effectively receiving the support they need. Typically at children, it's going to be 60 minutes weekly or every other week. We recommend weekly, but sometimes insurance visits compromise us and we might have to do it every other week. We want to especially make sure our families are involved. They need to be integral in being able to support them. And we actually want feedback from them in skills and tasks that their children are having more difficulty in communicating in. Can we make that functional with the therapy that we're doing? We want to make sure that we're the ones setting appropriate goals and putting treatment plans in place, but each child's treatment plan is going to differ depending on their current level of functioning and where they are in therapy. Next, Karen. So what are some of the speech language treatment models that are working for us? For one, some of our children are using American Sign Language. It does allow them to create language, but some of our kids with fine motor difficulties as a comorbidity are having just as much difficulty in producing good physical approximations for the signs they're using. But if a child is in a system, some of our children are in preschools or in settings where they're using sign language. And so this is an appropriate model to support language as well. You can see AAC is a very functional communication model for us to use for treatment. But then there are many other multisensory approaches that are now evidence-based. Kaufman has a protocol that you can look at. The Prompt Institute is one that's been around for a while. And I gave you links to all of those, and so you'll have those to be able to look at. But it's at this point, they're the ones that are still holding out to the fact that the therapists using prompt therapy must be trained by that institute in order to be effective trainers. Sometimes what we've been doing at Children's for a while had someone in place that was doing some of the training, so we were able to implement it in multiple settings in this that program. Well, what we know is that usually a multidisciplinary approach is something that's going to work better. So the Child Apraxia Treatment Once Upon a Time Foundation put together a number of international programs to be able to start to look at, do we have some research that's going to support these types of models? You will have links again to get to all of those, but kind of some of the differences that we're seeing, these are all more multidimensional, but rest is fairly self-directed for speech pathologists to learn how to deliver treatment for children with childhood apraxia speech, and gives lots of information for both parents and therapists. The Newfield Dyspraxia Program, well, I'm having trouble today, is also one that has a very flexible, comprehensive assessment and therapy resource for the management of severe speech disorders. For all four of these, what we see is it may not be apraxia that they are focusing in their program, but what the research here is looking at is all of these have been proven effective for children with apraxia. And that's what they were trying to pull together in the McCabe study. The DTTC is a motor-based approach, and they're really focused on really looking at setting up and improving the brain's ability to plan and program movements for speech. And this is one that is more effective or focused on the CAS difficulties these kids are having. And then finally, the Integrated Phonological Awareness Program is also one that's designed for simultaneous facilitation of speech production, phonological awareness, and letter sound knowledge. So a number of individuals that are working with literacy programs feel these kids are having difficulty. This is also focusing on that as well. So what do we know about what is effective treatment supposed to look like? You can see the different protocols that are already in place and are being more research-based, but for all of our kids, age is going to make a difference. How early can we get them in therapy? And it's neat that we now have some evidence for our infants and toddlers that we can get them in as early as possible. Severity is also going to guide, if they're going to be more difficult. The kids that are more severe, have less phonological processes in place for them, are going to be more difficult as well. The other thing that we're seeing is the level and intensity of our intervention. Can we set it up? Murray did a really interesting study on looking at doing it 4 times a week in blocks of 12 to 15 sessions, followed by a 4 to 6 week break. And that might fit with some of our families, with being able to effectively spend some block time with it, and then seeing if just some of that carryover during the break holds in place. In 2012, Eudor and Goldstein Newman started to look at the effect of treatment intensity. And they did find that the more effective the therapy and the more efficient the progress in those where the intensity was higher. And the other thing that we've been talking about are any children with coexisting diagnoses are going to make it more difficult. And we need to look at who are going to be the other therapists that need to be on our team to be able to address the children in a more holistic way. And then always our families. We want to make sure, is this doable for them? Can they provide the opportunities at home for home practice? We know that therapy just done in the therapy environment is not going to be carried over unless it's part of a home practice program. So finding out what's doable for the families and can they implement that as well. Okay, Karen, back to you. Did I have any other questions?
Let's see, let's look in the chat. Yeah, oh, we've got some personal experience. Thank you, Risha, for sharing that. Grace uses the touch chat and it really is working well for him, and comments about how everyone loves AAC. Any other questions before we move on to our case study? We're running ahead of time, so that's good. All right. So I'm going to talk about, so this was kind of how Oscar presented all of those characteristics that Sandy described of infants and toddlers was how Oscar presented. He had very little babbling as an infant. He had only, and really it's Aaron that we're talking about, only had vowels, not consonants, very interested in communicating. And so he initially presented as a 2.5-year-old with an evaluation. That was his initial presentation. Let me move this so you can see. His initial presentation to developmental behavioral pediatrics was at age 2, where the question was, does he have an autism spectrum disorder? Does he have developmental delay? What is going on? And the evaluations that included psychology, speech and language, occupational therapy, found that he did not have an autism spectrum disorder, but he did have a communication disorder. He had a mild developmental delay, a mild problem solving or cognitive approach, and his fine motor skills and coordination were below his age level. His communication skills, he was in the kind of low average, not below average, and you know the difference. So low average is kind of like the borderline of average. Below average means lower than that. He's in the low average range, so still looking at average for understanding speech, right? His receptive speech was right there. But what was severe was his ability to express himself. He had severe expressive delays at age 2, might have been 2.5. In terms of his problem solving, his judgment, his thinking, his cognitive skills were mildly delayed, and fine motor and coordination, he had trouble manipulating fine motor things, coordinating simple movements like picking up things. Those were below average. So at that point in time, that when he was at 2, he was given a developmental delay. When he was 4, he was reevaluated, and at that point in time, his diagnoses were global developmental delay, meaning at least 2 domains of development were affected. And in his case, it was communication, a little bit of problem solving or cognitive delay, and a little bit of fine motor. He had childhood apraxia of speech, was diagnosable at age 4.5. He had both a mixed receptive, a mild receptive, and a more severe expressive language disorder. He had a coordination disorder. He had sensory processing difficulties, and he had some ADHD. He had struggles with being distracted.
Because we saw him initially at age 3, that was the first time we could actually do an evaluation that addressed the childhood apraxia speech, even though he had all of those symptoms that we were talking about earlier with the infant and toddler. We didn't really have enough evidence at that point. We could suspect CAS, but we really couldn't, we didn't have enough definition to be able to define it. And I think now with all the research we're doing with these little guys, we can jump in early on and have more indications of whether we should be going the route of treating the apraxia as opposed to just treating a developmental articulation disorder.
Thank you. That's so important to be able to know when we can identify what are the appropriate diagnoses that will help him in craft his treatment. Really appreciate that. And that can be very challenging and difficult for families in that, you know, what do you mean you can't give me all of the information or all of the clear diagnostic profile? And so often with the 2, 3, and 4-year-olds, it just is not clear, and you wouldn't want to label or make a diagnosis that wasn't founded in enough characteristics, enough components to be able to make a definitive diagnosis. So that is very challenging as young ages. So at 6, he had a reevaluation from a multidisciplinary perspective. And at that point, his communication struggles were childhood apraxia of speech with moderate delays in his receptive. So as he was getting older, we were noticing more difficulties with understanding and comprehending all of the speech because the bar is raised, right? The older you get, the higher the expectations for your ability to communicate both receptively and expressively. He still had severe delays in his expressive difficulties. He continued to have this amazing personality, which has continued. I still see him. I just saw him a couple months ago, and he's just got this great temperament, just like Oscar. Has this great temperament and has a no can do attitude, you know, or a can do attitude that just helps him through a lot of the difficulties and some of the stigma that folks were talking about in the chat. And maybe we can talk a little bit about that more later if anybody wants to bring that up. We did IQ and cognitive evaluations and found he had in the low average range for his nonverbal IQ, and that's his ability to problem solve, its ability to understand his world with use of pictures, less about language and words, his judgment, his reasoning, those sorts of, that was in 85, and that's in the kind of low average range, not below average. His verbal IQ, though, look at the difference. That's at least a 30-point spread, and that's a significant difference. So you can see how folks would look at him and think that he has more learning difficulties and more intellect difficulties going on than he does. And it's because of the childhood apraxia of speech and his language communication difficulties. His verbal IQ was 55, which is in the disability range. So he's got this spread that makes it very difficult to interpret what his full IQ is. And so you wouldn't want to do that to him because he's better understood if you look at each of these indices separately, knowing that his verbal intellect is significantly different from his nonverbal problem-solving approach. His fine motor skills were in the below average range, and that's his pencil, grasp, handwriting, coordination. His learning, he had started, you know, so he's in kindergarten at this point in time, and he was below average in reading and math. Reading has continued to be one of his biggest struggles. And he's in the low average range, knows the difference. So he's doing better in his knowledge and his visual learning. So he is a child who responds best to learning in a certain style and more visually than language based. His behavior at that point in time was pretty inattentive, pretty impulsive. He had a lot of trouble waiting for things and pretty hyperactive at age 6. He was sensory seeking a lot of the time. And his diagnoses at that point at age 6 were childhood apraxia of speech with a mixed receptive and expressive language delay. He's at risk for a learning disability because that was not diagnosable at that time, but we thought he had a language-based learning problem. He had attention deficit hyperactivity disorder, the combined type, which is combined impulsive hyperactive type with the inattentive type, and then probable developmental coordination disorder that really isn't really diagnosable till around the age of 8, and a sensory processing disorder. So fast forward to the rest of the story. So in 2nd grade, some of his learning struggles were coming out. He had an IEP and he was getting intervention services for his reading, his math. In school, they were using his device, and that helped school to see how much more he could comprehend than he could express verbally. So that was a huge help to his grades and his learning, and the reason why his knowledge was growing, even though he would struggle in things such as reading. He had both school-based speech therapy and private-based speech therapy where they used his device and taught the family how to use the device. So as his skills grew, they could build in those extra cells that he needed for composition, putting sentences together, words, and paragraphs. He did end up repeating 1st grade. He was using 2 to 3 word sentences at that point, but longer sentences with using his speech device. He still had, I've been doing this a number of years and I still could not really understand what he was saying. His mother, of course, was tremendous. And she would say she could understand at that age about 50% of what he said. But, you knew the context. So if you know the context, you could understand a lot better. He was starting to get frustrated with the difficulties this created with teachers, but he never got frustrated with his friends. His friends, he was a very physical kid, and so he and his friends, he had a lot of friends. He knew how to make friends, and they didn't worry too much that they didn't understand what he was saying. He used everything he could to communicate what he wanted to say. His intent to communicate was always there. In 2nd grade, he did learn to tie his shoes, and that's a big coordination piece that our OTs and PTs who work with children with developmental coordination disorder have done a lot in the way of helping children with this kind of disorder learn how to do that in a way that works best for them, not what works best for the therapist. Here he is, fast forward to 11th grade. He has an IEP for a learning disability. His learning disability is the area of reading more than math. He has great supports in place. He no longer uses the speech device and doesn't need it in the classroom. He's able to compose, he's able to speak with intelligibility that his teachers now understand him. He does tend to be more immature in his friend choice. He prefers younger age children rather than children his age, and that kind of matches with his emotional maturity. Questions about Erin and her thoughts about the case presentation that we have before we move on to resources?
Go back to Erin, the last slide.
Okay.
Or, I'm sorry, not Erin, Oscar.
Oscar, yeah. Well, it is Erin essentially for all.
Yes.
It's Erin.
Yeah, I know. We're hiding him. Just a question back to the group. Why do you think we see such a big change between his ability to want to use his device now versus the time that he spent using it in 2nd grade? And as therapists, should we be pushing what level of intelligibility do we want them to reach before we say, okay, it's okay not to have that device?
I will add before anyone says anything that it took until 10th grade for him to be able to be intelligible enough that his teachers understood him and that he didn't always need to look to mom to interpret what he was saying. It took quite a while, and he has had speech therapy consistently since age 4, nonstop. It's made a difference.
Anyone want to volunteer a comment, or is this what you think you would see, not see? Would you advocate for something else? You can use the chat or unmute yourself.
I'm going to add to your question, Sandy, if that's okay.
Yep.
If we could talk a little bit about the effect that this had on his social development, both in school and with his neighborhood friends. If anyone could venture a guess how that went for him and what could occur with being different, with his differences.
I could imagine that socially it was hard for him to use the device to communicate with other kids or just people who weren't familiar with it, and being more in high school and not around maybe kids who are using a device, not wanting to use it as much if he can rely on his speech a little bit more.
Thanks, Kate. That is what happened. It actually started before high school. It was around 6th grade. He was in a parochial school for most of his elementary years. And whereas they were okay at using the device, he was not as fond of using it at school because he felt that he stood out. And that was about 6th grade when that started to really affect him. And so family, how would you work that with a 6th grader? What would you recommend that could be helpful? Oh, Jason, you raised your hand. I can see that. Thank you.
Yeah, I'm just curious if some of it had to, because I know AAC devices and stuff before, and I don't know what, how it was or how they do it exactly within his timeline of things, but they used to be more of boards rather than having a tablet or something, and tablets have been more now. I could see that in some ways also being helpful because people are more used to tablets in some ways and sort of a specialized communication device.
Sandy, do you want to comment on that? It's a great comment.
No, I agree totally. Just across the board, acceptance, since we have moved to so many robust systems on the tablets or iPads, has made a huge difference in the acceptability. Our kiddos needing them for their IEP are being taunted by their peers about, oh, I want to use that, or can I use that with you? Or so I think it's made a huge difference in just the switch from the more dedicated devices to these technology or iTab systems.
Yeah, Risha had mentioned in the chat that younger kids may be more acceptable of him.
Thanks, Angel, for bringing that up, because that was true. So in some cases, older children will accept children who have some differences. In his case, that was the maturity level where he was functioning, and he had some great friends, and most of them were of a younger age, and that was the right fit for him. In his neighborhood, he was just a star. So that's a really good point to make. Thank you.
Risha, you said too that Grace uses touch chat on her device. Do you see differences between Oscar and Grace, or things that have been when she had her system, or just tell a little more about Grace, if you're willing to share that?
Oh, no problem. Grace is nonverbal autistic. She just turned 13. And one thing I did notice, she just changed schools. The school she is at now is 90% of the kids are nonverbal. So I've noticed how much better and more she uses her device. Whereas at the other school, her device would come home with people's pictures on it and everything, older kids, you know. But now she's around more kids her own age. Everybody uses. She's doing much better. And I think she feels more accepted. You know, she actually has a friend at school. Grace ain't never had no friend at school, you know. Some older guy, they eat together, you know. But I like touch chat. I like her learning to use her words, you know. So it is very good for her. And I can see the progression with the device. We did use a book and it just didn't work for her. Technology and the iPad is just so much better for her. So much better for her. You know, it just didn't hold her interest. She wanted to play with the cards. Once we got the device, it was just so much better for her.
We hear that story again and again. What else could help with there can be a stigma associated with feeling different. And it wasn't sixth grade that was a turning point for Aaron, that he felt different. What are some resources that could be put in place to help him with those feelings and emotions?
Patricia raised her hand. Patricia, did.
Yeah, I raised it before that question was posed.
Yeah.
But what I was going to say is that my granddaughter, when they first, she was diagnosed with apraxia, but she's 24. And the approach then is totally different than the approach now. So the device that she got just basically said a word so that she could string words together, like I am hungry, or something to that effect. But so she actually didn't like the device. And so she uses, as a secondary language, she uses sign language, American Sign Language. And she's not as, because she also has some difficulty with fine motor skills, and in particular the pincer grasp. But so she has her own version of sign language.
Little idiosyncratic.
Yeah, but one of the things that really came out is that she does some of the frustration that we see is because she can't communicate what she's thinking. And so it's quite, you know, the best way that I articulate it to people is that it's like a person who has had a stroke. They know what they want to say, it's just not coming out. And that can create some form of frustration, and also some issues with socialization. She does much better when she's with her peers who also have some type of disability. She does a lot better. She and many of we hit a wall where basically speech therapy said, well, there's nothing else to teach her, which was incorrect, because when they stopped, I took it up. And she has continued to grow and to blossom because developmentally she was catching up, you know. And so I think that's something that definitely needs to be revisited, and I know it's based on what they say research says, but I know for sure, and I didn't even realize I was doing some of the things you all are saying. For instance, I taught her, if she didn't know a word, to say the first letter of the word. And then I also taught her how to break the word down into syllables. So she'll cover it up, cover up on work. So basically I'm not trained in this, but I knew to do this. So she has continued to grow even once speech therapy stopped. So, and that's something that to me, and I'm hoping that as all the changes are occurring in facilities that cater toward children with disabilities or who live with disabilities, that they'll begin to see that that sometimes stopping is not the answer, because they are still catching up with other children developmentally. So whereas many kids will stop at 18 with developing certain things, these kids don't. It may be 21 or 23. But then also I understand that insurance kicks in as well, and that's an issue. But so her secondary mode of communication is sign language. And then we also reinforce use your words. So.
Oh, thank you for sharing that, because it really does support exactly what we were trying to get more research in this area, is being able to substantiate that these kids do not need to stop because they're at a certain age. Developmentally, they are continuing on at a rapid rate, usually because now language makes more sense. They're able to use it in more modes of operation. And so it's trying to get that evidence into the next level with individuals with developmental disabilities do not have to stop treatment at that point.
I think also the feature of the output from a speech device or an iPad, or that helps reinforce for the child what the word sounds like. And sometimes kids can be good imitators, and with practice can do that, you know, kind of like what they do, I think, with the prompting method, Sandy, practice, and get that more intelligible speech.
Yes. Well, you know, and I think that same point is what you were even saying, Patricia, is that having a system available for her to be able to use and practice, and we're getting more opportunities, kids and young adults, and us, we adults are in the same way. Having that technology available allows us to have the model that they can build from, and being able to being viewed as being an acceptable mode of communication that it wasn't before. So, and the more we practice, the more we learn how to use systems. So yes, I think we're in a good place than where we were 20 years ago, when I feel like we were still inventing all of this. So the other thing that our research is telling us is that having communication systems like this in place allows us to practice at a higher level of communication. So having individuals model, whether it's family members, peers, that modeling piece has been huge, and individuals continue to develop their skills, and modeling at a level that's higher than what you have the system or what we're expecting them to be able to communicate at. Our most recent research in AAC is telling us modeling on a system that has 45 to 60 words is a more appropriate place to be for almost everybody, because we're speaking at that language level. And if we are modeling, then they're also getting a higher level of modeling for language. So those are all things that the AAC world is beginning to show us as effective means of communication.
Thank you. And Jason, I saw you raise your hand.
Yeah, speaking of prompting, and I know this is a controversial thing. I know at Syracuse, they're looking at this at one of the centers that they have that is now conglomerated within a couple of different centers of disability. Within it is rapid prompting method, which still needs the evidence base behind it, because there's concerns of that somebody would be manipulating the actual message rather than the person themselves. But I know for some people it with some muscle dexterity. It's been wondering if people could build up that skill with some of that. So I was wondering your thoughts or comments about that. I know that might be a little bit different, even though it is with AAC, because some of that is about the physio-muscular stuff.
So from a prompting perspective, it's really making sure that you're able to demonstrate that the individual we can do a certain level of prompting, but the individual is the one that is generating the response or creating the questions or giving the comments or statements. I think where we come from with the prompting is really getting back to what language level are we giving them to use? So it's teaching them the language, prompting them, this is how you can find it. So it's in the instruction mode that we're providing it, rather than prompting them to come up with a specific answer.
Yeah, and I know some of that with that is when it's supposed to be thought of and doing it right, and there's still questions about and research around it, is being able to help with sort of the tenacity of something for somebody, and being able to provide some of that support within, like, how do you do that without actually doing that? And I know they're still researching whether that's actually something that it is. And right now it seems like, understandably, there's skepticism to that.
I'm not skeptical of it.
Yeah,
I think, yes.
Not trying to say
you're right. We have to have more research, and it's harder too as we get into the young adult ages and other ages where you don't know what the background is, how much has been provided for them, and they don't have the variety of information we want them to pull from to be able to give their answers or ask their questions. So I think it's getting more difficult, but by having all the eye technology out there and being available to individuals at an earlier age, I think we're all more comfortable with what we're providing and the opportunities to be able to choose your own response.
Thank you. I appreciate it, discussing it. Thank you.
And could someone take a stab at what kind of resources might be available to help children who might feel different? How would we handle that? Our psychology trainees, our social work trainees, any of our trainees, take a stab at it. It's a tough one. What resources might be available at school? Sometimes it's at school where the teachers notice that the child is pulling back or not participating as much, and might even make some, have some behaviors, or might make some comments that they don't have any friends at school. And if someone's raising their hand, I can't always see it because of the screen I'm on.
You can use a counselor. I mean, mental health therapy, any of those kind of connections, I think would be really important to at least advise and consider.
Yeah, thanks, Christy.
And I know some schools have like social skills groups for individuals where they have like it at lunch or recess, depending on the age. So they can those skills.
That's a great resource that I think is untapped several times, the social skills, and families can have it built into the IEP also.
I'm also wondering about what's available online, social groups via the web or different types of organizations where kids and even teens can meet virtually given the pandemic, and that might make them feel more comfortable talking through these types of issues.
Risha
There are-
said, I just explained to Grace, these are your words. I don't know.
What was that, Sandy? I missed that.
Risha, do you want to verbally respond and add anything to that for Karen?
Yes, yeah, we're talking about if the kids feel differently. I always explain to Grace that these are your words. You know, this is how you talk. These are your words, you know. And we've been doing that for years with her, and she's more receptive. She used to didn't carry her device, but now she does. So it makes a big difference.
Great way. Thank you. Great way to frame it. Yeah. In Aaron's case, it was his family who he started saying, I feel different. I'm not sure how. And they did go that I think Megan was talking about, or maybe it was Alex, they did go the counseling route, and that made a big difference for him. He recognized he had special talents that other children didn't have, and there were special areas that he struggled with, and it made a huge difference for him. Jason, you have your hand up. Yeah.
Yeah, I think that goes into some of what I'm thinking when I've learned about some of this stuff. And for my own journey, it's about, you know, you get so much focus on disability is what you can't do and what you're bad at. And also being able to see that there are other people with disabilities, and there's other within that, the people who do things, and being able to see it as be able to have it as not just a negative, but there's and being able to find sometimes people who maybe understand some of the things that you've gone through, or, you know, because they're also doing some similar, and there might be similar ways that you all like to hang out, or, you know, being able to not just think of it as the thing that you're trying to overcome or be normal, or that there's, you know, that you're different but not less.
Yeah.
Excellent way to frame that. Thank you. All right.
Karen, I was going to say, but there's another piece to that, and that's the kids who have some developmental delays or disabilities, who cannot articulate those emotions, but they still need to be dealt, you know, they still need to be addressed. And that to me is still, there's not a solution yet. So it's, you know, I'm not sure if the thinking is they're not thinking about it, but they're thinking about it. If they're thinking about other things, or they're experiencing it without knowing what it is. But that's one niche and one area that I think still needs to be addressed. And that is those who cannot articulate, I feel different. But when they see other children move away from them, they sense something. And that, I don't know if that's our psychology graduate students who might want to take this up as a research project. But that needs to be addressed, because these kids are still suffering. They're still suffering. It's just that they're not able to articulate it.
Mm-hmm. You're getting support. Good point from Megan and Christy. Great point as well. So
yeah, I think there's
thank you for making it.
I know there's changes in some of that, and also understanding from working with people who are in those communities who have been through it and who are going through it in some ways. While it doesn't 100% say what is 100% going on, it gives us more to understand about how to make better environments to support people, how to be able to think about some of the different things that people are, because there are some similarities of experience based on external and also some internal things. And so being able to take some of those things from people with disabilities and being able to have sort of other observations of making sure that we know, because there's a lot of ways ways that behavior and other ways that people communicate too that we sort of notice. And it's a little bit tougher because language is based on the understanding of shared meaning, and shared meaning even within language can be different. But being able to sort of take some of those things, and I think that is starting to happen, especially as sort of groups of people are pushing for more and more understanding across the things. And I'm not saying it's perfect, because you're right. And I don't know if there's 100% ever. It can be 100% where we understand anybody for anything, but I think it's getting more able to be able to understand and think, especially as we're hearing from groups of people saying this has been my experience, or this has caused me things, or this is what a helpful environment might look like.
Absolutely. The advocate community has really opened our eyes to the issues that Pat's raising and that we all agree with. I've also seen recently some literature from parents who are recognizing that their children are lonely when those things occur that Pat was describing. And so the parents and self-advocates are really moving that mark. There are some early studies showing that just because you can't articulate it doesn't mean it isn't there, and particularly studies about loneliness. So that's a big area that needs more work.
Well, and what is meaningful, because different meaningful relationships can mean different things for different people, or what is considered, so being able to understand that, like what you said, Pat, about how you've noticed things about who your granddaughter's with and how that makes her, being able to notice that and be able to, and stuff, because that's going to be the important things in some ways, is that there's different ways that we sometimes only think of one way to set things up, or we want to completely systematize it, and how do we also customize it individually?
Yeah, absolutely. And speaking about Karen, the loneliness, she never got invited to the sleepovers. And if she was invited to birthday parties, it was usually birthday parties of other kids with disabilities. And so very early on, my daughter and I started what we call periodic unbirthday parties. And an unbirthday party is we get a birthday cake with candles, and we put all of her stuffed animals and her puppet animals around the table. And we had pin the tail on the donkey. We had balloons, we had hats, we had everything. And so just periodically we would do an unbirthday party, and all of her stuffed animals and stuff attended. So we had to do that because she just, she didn't get the invitations to the sleepovers and stuff.
Unfortunately, much too common. And look what a difference it made for her. We've had families do proms. If the children didn't go to their school prom, and they had a school prom. Thank you.
Yeah, I think some of it goes too with some of that stuff. And I know I had a lot of misunderstandings in school and stuff and different things. There's also teaching, like we do with other sort of subjects, or about disability as part of diversity and disability history and some of those things that, because unfortunately, because of the way that it is and some of the ways that disability has been housed, there's a lot of perceptions of what disability is and misperceptions that then goes into people's individual lives that we don't even realize until we look back. And while some of this is fixing the things around people with disabilities themselves, it's also looking at the way that we as a culture also think about it or treat it or don't talk about it, or sorry, I don't mean to be dogmatic or anything, but
yeah, you make excellent points.
No, and totally something that we need to consider, or not consider, but keep in front of us, that these are the kids that are being missed if we're not the ones that are pointing it out, no matter what team meetings we're at or what opportunities we have to be able to bring on other advocates, and that whatever setting they're in is so important. Because that's, I think, as a professional, that's one of the hard things I have. I can do trainings, I can give information, be there, but then if we don't have someone on board that's going to be able to make sure that we're providing lots of opportunities for them to communicate, provide them other ways to be able to share that this is hard for me, or I want to do something different, or all the things that might be affecting them, then it's not going to happen. So it needs to be us outside of the research training environment as well. So hopefully. So the last slide here is I just wanted to provide you with other links. The American Speech Language Association has a huge portal. It's open to anyone to be able to access on childhood apraxia of speech, links it to research, links it to other resources. The Apraxia Kids website is also very good. I send a lot of parents and other teachers and that to that. They have a very diverse website for looking at not just research that's been done, but resources in your area. And then here in Cincinnati, we've got St. Rita's School for the Deaf Apraxia program. That has been in place probably for about 15 years now.